Hello, welcome to Drugs Unwrapped with me, Rob. Today I'm joined by Sian, who is Barod's operations manager, and also Dr. Joe Janes, who is a lecturer in criminology at Swansea Uni. Welcome both. How are we?
Good, thank you. Glad to be here.
Excellent. Joe, to bring you in straight away, so obviously you work Swansea Uni, so within academia, so hot off the press, any recent research publications?
Yeah, so I've been doing a project recently with a few festivals in the UK looking specifically at harm reduction and drug testing or drug checking, especially with the rise of overdoses at UK festivals as a harm reduction technique to give people safe advice in the moment. Something we explored, it was 2 years ago now, we did Glastonbury, Boardmasters and Leeds with a group of researchers to try and find some data around whether people would feel comfortable using a service that allowed to test their substances. And one of the most significant findings is that yes, although maybe not if it's run by the police itself. So definitely rather than by a welfare service in particular. So yeah, that was published in the last couple of weeks, particularly looking, like I said, at harm reduction at UK festivals and events.
Although in terms of demographics, I don't know whether this was something that you found in your research, but was there a particular age group that would more engage with like a drug checking service? I'm thinking like, you know, just perception wise, more young people rather than people in like over 40 over 50s. Was that something that came up at all, or?
Well, yeah, I think depending on the different demographics of festivals, something like Glastonbury, there is a young demographic, but Glastonbury is a much more open festival to all sort of ages, whereas somewhere like Boardmasters, for example, has a younger demographic anyway. The same for Leeds, you're probably talking 16 to 25 is probably the sort of age category. So yes, on one hand, in terms of the likelihood of using a service, but in terms of understanding the stigma of using a service like this, maybe someone from a younger generation wouldn't be as comfortable talking about substances because of that stigma, and especially the lack of education in schools. That was another quite significant finding, is that it just isn't talked about in education. That most education on substance use in the UK is still the just say no techniques of avoid, don't do this is a really scary topic and narrative, as opposed to this is an understanding of what substances are. To educate and inform, and I think that's where the harm reduction side of things becomes more vital.
That's quite surprising hearing like still a lot of the messages around just saying, is that the same in like universities? Because I think across the board you tend to find more of like a zero tolerance policy. I know a few unis have taken a different approach now, obviously not to name any specific unis in terms of either or, but do you find that when talking about colleagues that zero tolerance approach is still the norm?
Yeah, it is. There are a number of universities, without naming specifics, that do have harm reduction based policies. There isn't a go out and use drugs policy. That's not what this is about. But there is a move away from zero tolerance, which from the outset as a strategy is actually really important. There are discussions at the moment in some universities that I'm part of around changing some of that, especially in light of recent case studies. And again, going back to that point about people dying, and that's what this is about, preventing that. And I think that's something that I would like to see happen at the universities as well. It might not just be the Just Say No campaign, but it's the same sort of rhetoric of this is dangerous and scary, let's run away from it, rather than have honest, frank conversations about what substances are and the harms that come with them.
Yeah, I think Barod are making strides in that space as well. But, you know, in Wales is all I can speak about really, and the services we deliver. But we've got some brilliant toolkits that our services have been really innovative in that approach. So they're equipping teachers and school-based staff in really changing and shifting that thought process and mindset away from Just Say No campaign that's actually quite dangerous to thinking about harm reduction and getting that message into schools delivered by teachers where children and young people have already got those relationships. So it's great to see that Barod are once again ahead of the curve.
Absolutely. But to get back to the topic at hand, so Spike on a Bike.
Yeah.
So Sian, you are the brain behind Spike on a Bike. That's true, right? Yeah.
That's true.
Yeah. Excellent. So I guess start from scratch. What is Spike on a Bike and how did it come about?
So Spike on a Bike is a service, a harm reduction service that delivers needle exchange provision, harm reduction provision, overdose awareness and prevention to people in a mobile way into the community to exactly where they are and where they choose to receive that service for. It's a service that's delivered on bikes. So we've got fully kitted out bikes that allows us to carry equipment, allows us to pick up waste from the community, drug-related, alcohol-related litter, and allows people to get that service where they are when they need it. And that's available 5 days a week. And people, if they place an order before 3 o'clock, they can have that delivered on the day, anytime between 3 and 5. And where it came from, the idea actually came 10 years before it actually became a reality. I was working with, I always talk about Stan because his name wasn't Stan in real life. I've obviously anonymised his name. But Stan, if you imagine a person who injects drugs, he was a groin injecting heroin user at the time, and he'd already had one leg amputated from poor injecting practice. Using heroin, had multiple overdoses during his time. He was Hep C positive, likely to be resharing works as well because he lived on the Ceredigion-Carmarthenshire border, which was really, really rural. It's like a kind of place where there's only one bus a week to the nearest town of Aberystwyth. And I was thinking, my gosh, at the time, the service I worked for really wasn't equipped to be able to deliver this service that he needed and the harm reduction equipment. We didn't have outreach workers in the same way as we had then. And I remember asking my then service manager, wasn't with Barod, was with a different service, can we do something? I had the idea then of, can we take a mobile harm reduction service to people out in these really rural parts in our communities to reach people that fall through the net, that are harder to reach. And I was met with a totally resounding no. And I think part of that was about budget, part of it was about the appetite for that kind of innovation at the time. And I very much got the impression that the world just really wasn't ready for that idea. And then we fast forward 10 years later to 2020 and we're faced with a pandemic situation. And at the time, I was a service manager for Dyfed Drug and Alcohol Services, led by Barod, supported by Kaleidoscope and G4S. And what we saw in terms of our needle exchange service provision was a big shift in people accessing needle exchange provision itself. So I've got some of the stats here. We saw a 39% reduction in the number of transactions we were doing in our needle exchanges across the Dyfed patch, and 34% reduction in the number of new registrations, new people coming in and actually accessing our exchange, and 41% less items dispensed through our needle exchange. Now, as anyone working in a harm reduction service, that provided a huge amount of worry for me because people were still injecting drugs. They didn't, that didn't just disappear overnight because we had a global pandemic. And what we started to see were these pockets of new emergence of bloodborne viruses, particularly hepatitis C in our communities. And that's because people were sharing equipment. They couldn't get into a needle exchange facility or a pharmacy because they had limited opening hours. People were in enforced lockdown and were worried about having a fine maybe for leaving the house. A lot of people were shielding. A lot of people who use our services were shielding as well because they have compromised immune systems, may have other physical health concerns, maybe HIV positive or end-stage liver disease. We saw people dying. When we look at the drug-related deaths during and after COVID, we saw those deaths increase and people were overdosing. People weren't able to go to A&E or their GP surgery because it was an absolute nightmare to get a GP appointment, or people were really afraid to go into those clinical settings because they were worried about catching COVID. So what we saw is just this huge drop-off in people being able to access us, and I thought, maybe the world's ready. Maybe this is our time for Spike on a Bike to become a reality.
It's crazy what was able to just be put in place in COVID as well, when we look at other aspects of like harm reduction. And also I remember in terms of suddenly people who were homeless or experiencing homelessness, suddenly, you know, those individuals could be provided accommodation and stuff like that. I find it quite crazy really in terms of what was possible and always been possible really from that.
Yeah, absolutely. And everything moved so fast, you know, even working as for a third sector charity where things move a lot quicker day to day. You know, even during COVID, I think the innovation that happened and it just transformed the way people think about things, or it removed barriers because the risks were just so much greater than they'd ever been before, that the risks of actually trying something new were bound to be less. So I think it just allowed us to be more creative in how we solve problems.
So when did Spike on a Bike actually start?
2021, so November 2021.
Okay, so we're looking for 3.5 years.
Yeah. Yeah.
It's pretty good.
And we've had some amazing times with it. We've learned a lot with it, based on the nature of the project. And it's just made a difference to people's lives. And that's what's been really important, is people accessing that type of service that wouldn't come into normal, I say normal for want of a better word, but your traditional fixed site needle exchanges or your fixed site office based service provision.
I think, yeah, going back to that point around Stan that you talked about, that service user who was injecting heroin into their groin, and maybe the world wasn't yet ready for Spike on a Bike to really start and become what it is now. I think the key point is around this could work in any community. So it doesn't necessarily have to be focused on rurality, but it is even more important in a rural area. So, you know, that's the point you're talking about here, is that person, Stan in this case, wasn't maybe able to access services 10 years ago. And then COVID personified those people who live in rural communities who couldn't access those services. So that's the one layer. The second layer is then the stigma. If you're the only person walking down the street to go to a fixed site service, it becomes very obvious when you're the only person every day who's walking up to a fixed site service. And I think that's building on that and understanding how stigma really interplays with people using services in general. And for maybe the first time, it started to shine a light on those complex cases and how actually there are quite simplistic solutions if we just listen to those who use services, about how we can get out into the community and work with people rather than work against people.
Yeah, absolutely. Can we still say Spike on a Bike is the only one of its kind in Europe?
We can. Just to reference, the model that this is based on came from a project in Vancouver called Spikes on Bikes. And they weren't motorbikes or mopeds, they were actually bicycles. And it was a much more urban city centre where people were going out with naloxone rather than needle exchange equipment and other provision. And it was much more about the overdoses happening within the urban city centre there. Okay. And that's where kind of the idea came from. And we needed something to adapt to a more rural geography like Dyfed. Like Joe was saying, you know, to reduce that stigma in populations where everybody knows everybody knows everybody's business, everybody's talking about everybody's business, and there isn't always the kindest stereotype attached to the people that we work with. And Spike on a Bike was one of those ways that we could deliver a service for people and help address that problem that is stigma.
There was a really nice quote that we saw that came through the data itself within the research for Spike on a Bike, which looked at how in the lady was talking about in the 1980s and early 1990s, it was more difficult to get hold of needles. It was easier to get hold of heroin. And so then she would go into a pharmacy and try and get hold of needles for her and her friend who was using at the time. Whereas now, it's a lot easier to get hold of needles and sharps and that harm reduction equipment. And a project like Spike on a Bike does exactly that. It's getting out into the community to help people use safely, because we know people use substances. We do. Everybody uses drugs in their own ways, and whether we're talking about alcohol or paracetamol, people use substances to go about their daily life. And if we can make that harm reduce, then that's going to be for the better, and it works within those communities.
And I think within rural communities as well, I mean, of course it happens in city centres and in urban areas, but there is so much hidden in terms of harms that people who use our services or people who use drugs experience, that it makes it even harder in terms of that intersectionality of some of these problems. Like if somebody, for example, is experiencing domestic violence, or they're in a relationship that's got coercive control, it's much harder for people like that to leave home sometimes and be able to access safe equipment or safe provision or good advice, or even a listening ear. Spike on a Bike revolutionises that, because if somebody is being controlled and they're not allowed to leave the house, or don't feel able to leave the house and that it's not safe, Spike on a Bike can take sometimes these life-saving interventions directly to somebody's door without putting them at further risk, or without putting them in situations that they feel uncomfortable or that could be potentially dangerous for them.
And exactly that, Sian. It's not just the equipment, it's the human element of meeting someone at the door. And for some service users who've engaged with Spike on a Bike, it might have taken 5 or 6 times for somebody to come to their door and deliver harm reduction equipment, for them to say, do you know what, I'm going to come into a fixed site service. I know you now. Will you meet me if I come in? And that's happened and developed from there. And there's some fantastic case studies of people who are now on script, who wouldn't have engaged or hadn't engaged with any harm reduction service at all, but after using a mobile harm reduction service and developing rapport with rider, all the riders are trained service providers, drug practitioners, they then came in and started using a fixed site service. So it's that next level.
That's huge, isn't it?
Yeah, that's exactly what it's about.
You look at other harm reduction interventions, and some of which are currently illegal for us to provide. We look at safer inhalation devices. The research suggests that be able to provide a harm reduction intervention as simple as that can be the gateway to people engage in treatment, and obviously Spike on a Bike therefore shows that is a prime example of that happening really as well. So things that people can get from Spike on a Bike, so obviously we talked about sterile kind of injection equipment, naloxone, DBS, dry blood spot testing.
Yeah, so they can have a HIV, hepatitis B or hepatitis C test, or all three if they wish, and that isn't anything scary. It's literally a pinprick to the finger that can be done as long as we've got a clean environment. It doesn't take very long, so if people are in a rush or people are wanting to do that really discreetly, we can do that. They don't even have to have injecting equipment, so things like foil, things like food vouchers, things like naloxone, we provide that, as well as some training around overdose prevention and awareness and advice. People can also just have a chat and just get some advice or make a referral curbside, because sometimes I think people have a idea of what treatment services look like. They may have a really archaic view of what we offer and what we are about. So they might be worried about coming in and having a lecture, or might be worried about being told that they've got to stop using the drug or alcohol of their choice. And actually that's not what we're about at all. And sometimes just having that opportunity to have a face-to-face conversation or put a face to a name can really alleviate people's nerves about coming into a base, or even having a digital appointment with us, which is also something that we offer. So there's a whole suite of things that people can access with us, even things like a leaflet, someone's new to injecting, they're really not sure where to start, or somebody might be using image and performance enhancing drugs and think, oh, I need a bit more advice or information about how I'm going to go about doing this so I'm informed. We can even deliver things like literature, important information that can really just make sure that people are as safe as possible before they embark on something new.
That's cool. And Joe, for you then, how did you get involved and what is your role within the Spike on a Bike?
So I was invited by the late Dave Bewley-Taylor and Professor Rick Lyons. They needed a researcher to come in and help with the project. I had a vested interest in harm reduction and getting involved in that research from my criminology side of things. And so I was invited down to meet the team and get involved with what was going on in DDAS. So yeah, that's where I sort of came in.
And the area planning board in Dyfed, there's a wonderful man called Dr. Gareth Morgan who works for Hywel Health Board, and he was like the glue that held us all together and made those initial introductions and connected all of us as a partnership. And unfortunately he can't be here today, but he was pivotal, really. He's won an award and everything, hasn't he?
Yeah,
Yeah.
What's he won an award for?
I think it's partnership working.
Is it?
I'm pretty sure it's partnership working within the health board, and Gareth is a fantastic individual when it comes to finding people who are passionate about changing the world. You need that glue to come into a project to align, because we're talking about 2-3 different universities. We're talking about Barod, DDAS, the health boards, Public Health Wales, collaborating on a project. And Gareth is what makes those people come together. And it's quite difficult when you talk about those different agencies and partners to get everyone around the table. Yeah. But it's been done in a way that the steering group is something that we all really look forward to taking part in. And it's brought so many other projects out from that. Yeah. And those discussions around how we can make changes across the board when it comes to substance use.
Dave started or came up with, you have to help me out here, with the GDPO, the Global Drugs Policy Observatory. And like Joe was saying, it's allowed us links into places that we would never have been able to make, particularly as service providers, just being linked in there. We both went and gave a presentation at the GDPO in Swansea University, but beyond that we met connections with other people, and since been to Manchester University, talked in Scotland about Spike on a Bike, people just really wanting to hear more after these connections have been brought together.
Yeah. That's what it's all about, isn't it? Collaboration.
Yeah.
So Joe, what's the data telling us then in terms of Spike on a Bike at the minute?
So there's some really interesting data, Rob, when we look at Spike on a Bike and what's sort of coming out of the service itself. One of the key takeaways to begin with is the demographics that are using the service. We're seeing a really high female uptake, upwards of about 38% of service users are female, which is higher than we would see in a fixed site service. So from a takeaway, that's really important. Engaging with people who might not necessarily or traditionally use a fixed site service. The other point then when we talk about demographics is young people. So we're seeing a lot of younger people under 40, we're talking about 20 to 30, quite high proportion of people using the service. So it's engaging with a demographic, again, that doesn't traditionally use services at all, not even fixed site services. So we're talking about working with people who don't traditionally engage. And that's really important, I think, from the data.
Is there any particular reason as to why we're seeing higher percentage of females? Do we know that?
I don't think we know that yet. I think the next phase of the research will want to look more into that. There is some data that suggests that women are stigmatized in various other ways when it comes to using services or using drugs in general. Sociologically, we talk about double deviance. So not only the deviance of using substances, but also the deviance of doing something you shouldn't when you're a woman. So we've got 2 points there that make it quite significantly more difficult for somebody to engage and not be stigmatized. I think that some of the wider literature talks about that, and how we can sort of open the door to all demographics for using support services.
I think what we do know as well from anecdotal feedback from people using our services, particularly Spike on a Bike, is the digital nature of them, and more things are becoming digital. I mean, Barod have got naloxone click and deliver services, we've got live Webchat services. It's more accessible. So there are people, particularly, a lot of our uptake in Spike on a Bike are people under the age of 40. People are more digitally connected, so you're much more likely to go on to an app or to go onto a website and place an order doing it that way than having to work around services perhaps that are not open 24 hours a day. So I think the accessibility of Spike on a Bike is one of the factors why we've attracted that demographic. The other thing, particularly around women, is, without generalising too much, largely women have most responsibility over childcare, looking after young babies or young children before they go to school. Spike on a Bike is such a service that's so flexible. They don't have to alter their lives and their childcare responsibilities around service timelines or a worker's availability for an appointment, or worrying about I can't take my child into a needle exchange, that wouldn't be appropriate, or worrying about the safeguarding responsibilities of that. Not to say that we don't have appropriate safeguarding discussions in those environments, but I think for women it's a service that can really blend with their way of life and their responsibilities that are perhaps different to those of men. And I do think as well, where you have got domestic violence happens in same-sex relationships, in heterosexual relationships with men and women as perpetrators. But I think in the main, what we do know is that domestic violence, largely females are the victim of domestic violence. And I think this kind of service allows people to access things directly to their door. So if there is issues of control, as I mentioned earlier, it's far more flexible around that.
So when we're talking about data, Joe, is there any particular data that you want but you just aren't getting at the minute?
So I think that when it comes to the next phase of research and understanding those demographics, that's really important. To be fair to the team within DDAS, they've been fantastic at collecting their own data. And that's something that's been really helpful in terms of understanding. What we want to do next is take that a little bit further and think about some of the financial implications of that to help the service in the longer term. One of the points of that is understanding some of the health economics and trying to work out what the actual cost benefit of a service like this is for NHS cost savings or improving the quality of somebody's life overall. And if we're taking a 20-year-old service user into account who may have not engaged with any services from 20 to 40, the health harms that may have been developed in those 20 years are really significant, even if we just look at bloodborne virus transmission. However, if we could engage with a 20-year-old person, male or female, to use a service like Spike on a Bike earlier, we could maybe mitigate some of those health harms and the secondary health harms that are involved in substance usage. So yeah, that's what I'd like to look at in a bit more detail.
And is there anything else that can be done to help sustain like the longevity of a service? Because obviously within like harm reduction, funding is, money makes the world go round, doesn't it? So, funding obviously is a pivotal part to ensure that services kind of continue. So is there anything additional that you think is needed to ensure that a service like this remains?
I think the key point there, Rob, is funding. It is always going to come back to that. Can you sustain grant funding to ensure projects like this continue? But at the same point, I think it's just having that data and getting the story across. We talk about journal articles being published and reports being published and data coming out of projects as being really important to this, because without that, we come back to this problem we have in all policy and creation of projects is initiativitis. We love having something new and shiny, like a magpie. We don't have, we have quite a problem, in the UK, Wales most definitely, but in the UK as well, of having to find something new. Whereas sometimes we may develop something that is really innovative and works really well, and we need to sustain, more important than having this new shiny productive thing. And Spike on a Bike is something that's proven to be a really effective harm reduction project. And it's how can we keep showing people that it is, and that it requires the attention, care and funding that it deserves.
Yeah. And I think as well, like you said, Sean, it only started November 21. So yeah, 3.5 years, isn't it? I think you need services to run probably a minimum of 5-10 years to really show its worth sometimes, isn't it? You know, to kind of get that kind of data and to show the impact it has. But Sian, do you think in terms of like with Spike on a Bike, with it being such a unique service, not just in Wales, the UK, but across Europe, do you think this kind of shows that actually policymakers and those ultimately who do hold the purse strings and who do make the decisions, that actually they should be more risk tolerant rather than risk averse?
I think that there's a lot that we can learn from the COVID time. You know, we've given several examples here today of how we managed to house everybody who was, homeless or without a fixed abode during COVID overnight. Things are possible. And whenever I go to speak about Spike on a Bike, and I think you do the same, Joe, is we urge policymakers to be bold, to be ambitious, to take a step of faith sometimes in things, because it's what we ask people like Stan to do every single day when they come into treatment services. It's what the community want people to do, you know, that the societal pressure to change. Why shouldn't our policymakers and our policy documents and our strategies and even the law be bold and stand up to what actually works and to try new things?
Yeah, because sometimes the biggest risk is doing nothing differently at all. And that's a real key thing. Being bold and doing stuff that's different and innovative to suit the people and the communities you serve is more important. So, and we are risk adverse as a society, and it's finding ways that we can do things better within the communities that we work in.
Particularly where we've got a body of evidence that something new works. So you mentioned earlier safe inhalation devices. There's a whole body of research and people are doing it elsewhere in the world where we know it makes a significant impact in terms of engagement, but also in terms of reduced harm. Things like enhanced harm reduction centres. You know, these are really important initiatives that can reduce drug-related deaths, that can reduce the cost of having to provide services after the fact. We need to be far more focused on prevention and how we can protect people and keep people safer before the worst happens.
Do you think, obviously, Spike on a Bike, with it being just West Wales at the minute, so yeah, Pembrokeshire, Carmarthenshire and Ceredigion, obviously we've talked about the rurality aspect of that, but Joe, do you think that model can work in a city centre, let's say Cardiff?
Yeah, I think it would work in an area like Cardiff. As Sian discussed earlier, this came from a pilot that was in Canada that was more urban than this is. And we're talking about rural areas here, but why not in Cardiff? It would work really well as an example. We're talking about a city area where you could easily allow this to be on bicycles and get it into the local community. Take an area like Swansea, for example, really high student population. We know that student populations use substances. So therefore, getting out into those areas, I think, would be really key. And within an inner city, even more so.
Sian, if we were to replicate Spike on a Bike, or if another area was to replicate Spike on a Bike, is there anything different you would have done? Or learning points that other areas could take on board?
Yeah, we have faced some significant challenges during the project, and setting something up like this that's so new. We didn't have a frame of reference, which if somebody else did now, which would be great, they'd be able to learn with us. I think one of the biggest challenges is appropriate storage of bikes. So I never thought that going into this would be such an issue.
Where are they stored now?
They're stored in various storage containers,
Okay.
public garages. But you do need to satisfy your insurance requirements in delivering a service like that. So it's got to be, in the CCTV enclosed environment, which limits you. So things like, lock-up centres, we weren't able to put them in lock-up centres because the bikes had petrol in them, which was a fire hazard. So it's things like that. So really think through where you're going to store your bikes if it's a bike approach you're going to take, or in city centres we were talking earlier about like e-bikes or bicycles that can be easier to store. Also, we are a charity. We don't have an endless pot of money that we can throw at this, so it's about how we utilise our existing resource, and that was also in terms of staff. So trying to ask existing trained drug and alcohol workers to ride a motorbike and go through motorbike training, motorbike licensing. That is another hurdle that you've got to overcome. It's not as easy as you'd think, but not everyone's as excited about being on a motorbike. And the other thing that I would like to mention is that in terms of motorbike gear, there's a real bias towards male protective equipment. So we actually had 3 female riders that wanted to do it, and when they went for their fitting, for their protective clothing, the clothing just didn't allow for hips and boobs. So yeah, it was a real bias. So it's about making sure that we can make sure that men and women, trans people, can also absolutely ride our bikes if they need to and have the appropriate gear.
That's incredible.
It's incredible, and it's a problem that we certainly didn't expect to face.
Do you see any developments within the service at all? Do you see any kind of add-on features to it? Is that in the pipeline? Not to give anything away if it is, if you can say, but yeah, are there any add-on features that either you would like or that is going to be happening?
I think really just building on what Sian was saying in terms of using, building on what Sian was saying, I think getting service users in from the start to discuss how this could be implemented in a new area would be really significant, because one of the key findings within Spike on a Bike research, where we've done it already within David, when we're thinking about how Spike on a Bike works, one of the key findings is people don't trust that it's real. People don't think that it's a real service, and that the police are just going to turn up at their door and be like, right, this is a known drug neighbourhood. And genuinely, a lot of people I spoke to had that, they were quite reluctant to use or engage with the service because they didn't think it was a real service. But then after using it the first time, realised, oh, it was. So then that's where the sort of peer-to-peer stuff comes in more there, is you're finding that this is becoming a trusted service. So if you could do that from the start and develop that rapport with current service users in a new area to share and spread the word as well as they can, then I think that would be quite beneficial to a new project area.
And I think that's a little bit of what we found as well, is when we were hearing about the research and some of the interviews with people who were using Spike on a Bike as a service, there was one quote that always stuck with me around somebody'd seen a poster for Spike on a Bike in their local GP surgery, and they were sat there and they were thinking, it's too good to be true, was their words. They quoted that. And that wasn't necessarily to do with the fact that they were suspicious that the police were going to show up. They just thought, wow, services have evolved to be able to do this. And they almost couldn't believe it based on some of their experiences before. So when you get good word of mouth, or when you get people who think, wow, that's an amazing idea, and actually have a good service as a result, it just flows from there, doesn't it?
In a few interviews, speaking with service users themselves from Spike on a Bike, we had some really powerful quotes that, like Sian is saying, that came at that. One of the most prominent ones was that I would never have engaged with services if it wasn't for Spike on a Bike. The way I live my life and how I live my life, using a fixed site service, trying to manage their work and their day-to-day consumption was really difficult. And seeing Spike on a Bike in a GP, scanning that code and coming in and eventually coming in, after engaging with a rider over 4 or 5 times, really significant. And that's something that's what this project's all about. Engaging with those communities who wouldn't traditionally use fixed site services.
Anything else you guys would like to mention at all? Have we missed anything?
I don't think we've missed anything specifically, but in terms of understanding the healthcare needs of rural communities, this project, without needing to from the start or wanting to from the start, has done that. We've started to shine a light on those inequalities that are faced in rural communities, and specifically hidden populations of substance users across Wales. People who just aren't accessing services for a variety of reasons, as we've discussed today. But it's how can we get out? Hidden communities are hidden. How do we speak to them? But how can we ensure that all people can engage with services and know that you're going to get a warm, trusting environment when you come into a service? You can't know that until you go in. And if there's stigma around getting into a project, how are you going to do that? And this sort of offers that grey area space between engagement and sort of dipping your toes into a service that I don't think really exists in other formats.
And just elaborating on what Joe was saying there, one of my biggest bugbears is the term hard to reach. People aren't hard to reach. They're there. They may be harder for us to engage with, but that's because it's hard for us. It's not hard for them necessarily. We haven't adapted services to be attractive or accessible enough for those individuals. So Spike on a Bike has really got us thinking, and hopefully we'll get other people thinking about how can we do things differently? How can we be braver and bolder in what services we commission, in what policies that we write? And do something different. Take a risk and do something different, because that's how we learn.
Sometimes if you're standing still, you're going backwards, aren't you? So
exactly
you need
that.
to push things forward. And hopefully you guys are on the road a little bit recently. Manchester, Sian, you mentioned. Did you go to Poland for the European Harm Reduction?
So I did Poland. Was it just before Christmas this year, which was, again, fantastic, really innovative. The conference itself was quite ironic that we were talking about harm reduction services, and the former mayor of Poland came out and did a really amazing speech on how harm reduction needed to be embedded in what we do and how we do it. There's a lot of people who are active substance users who were talking about their experiences within the conference itself. And then on the second day, there was a call put out via the conference app saying there are police outside spot checking people walking into the building because they've heard there's a drugs conference going on. And I just thought, how ironic is that we're trying to create a space that's about harm reduction and people coming together to discuss about how we use drugs safely and make the world a better place. And in the same breath, the police are outside checking things. So it is, quite moronic sometimes, but yeah.
I think it does. Those situations do make you think. I think there's loads of criticism about like drug policy in the UK, but something like that, I don't think you would see here, would you? So I know in terms of there's a drug policy index that's been done. And I know the UK came up quite high around that compared to other countries. But yeah, it's sometimes in a weird way, it's quite refreshing to know that that's something that I don't think we would see in the UK, which is, applaud UK drug policy a little bit, not too much.
It's been a really unique experience as a provider of services to work so closely with our research colleagues and our university colleagues. It certainly isn't something that I'd ever done before, and the way that we've combined our priorities and had a really shared vision right from the beginning has been pretty wonderful, hasn't it? It's been a really great journey, and a lot of people involved that I just like to thank, because one of the things that struck me is that everybody on the research team was as passionate about Spike on a Bike as I was, and that was really important because the evaluation of the project was running alongside us embedding it. So I think that's quite unique as well, to be able to evaluate a project right from the beginning as we did.
Yeah, I found it as a researcher fantastic. I love to, when I get involved in research, I like to get my teeth stuck into things, and to be able to be in the Barod office, well, be in DDAS's office and speak with service users, go to coffee mornings and get embedded in the service felt like you're understanding how the mechanisms work at the same time as trying to understand what the project aims to do, and seeing those things about rapport and building trust, and almost the people who are in a coffee morning are towards not the end of the journey, because the journeys may not have a start and end point, but they're very much on the way of trusting the service and being there. And you think that some of the people who are engaging with Spike on a Bike, in a couple of months' time, they'll be sat in that coffee morning having a discussion with service users and staff members about how to make their life a bit safer. And that is something that, for me as a researcher, abstractly looking at theory and being outside of things, you don't get to necessarily see day to day. To sit there and be there and experience and immerse myself in that has been fantastic. And the people that we've done it alongside, like you say, having that shared vision, whether we talk about Rick, Gareth, Dave, it's been fantastic to merge people together. And also a massive shout out to Paul from the sort of inception of things as well. We worked alongside Paul for the first year and a half of the project, and how helpful that really has been.
So Paul being the previous service manager for DDAS.
Yes. And to all the riders as well. I mean, you spoke to all of the riding staff, to the drug workers, and we were very lucky that we had quite a specialist skill in our existing team, in a chap called Steve, who built our website right from the ground and maintains it now and makes sure that we're high on the search engine optimization stuff. Is way above my head. Steve is much better talking about this, but he really made a difference in making sure that we were seen, we were visible if we were searched. And he's done an amazing job of building that site for us, as well as every rider who's been willing to actually jump on the back of a motorbike to deliver the services. So yeah, thanks all round.
Big time. It's quite ironic actually that as we're finishing this up, we can hear motorbikes going around the outside and being revved. I don't know if they're being picked up on the bike. There's some revving.
Yeah, if you want more information, you can go to spikeonabike.cymru. Joe, Sian, thank you very much. Thank you for both coming into Swansea today.
Diolch.
Thank you very much. Cheers, Rob.
Cool. Everyone else, we will see you soon. Bye-bye. If you have been affected by any of the issues discussed in today's podcast, please reach out. Barod have a free and confidential live web chat service that is available 7 days a week on our website at barod.cymru, where you can chat to a trained support worker. Alternatively, you can contact Wales's National Drug and Alcohol Helpline, Dan 24/7, either by calling 0808 808 2234 or text Dan to 81066.